So tonight we're going to be talking about a really very important yet somewhat neglected and underappreciated area in cancer, and that topic is communication. How do doctors discuss difficult diagnoses and treatments with cancer patients and their caregivers? And just as importantly, how do caregivers and patients speak openly and comfortably about their disease, their care, and important life decisions? We're fortunate to have an accomplished panel assembled this evening who are all leaders in the field of cancer communication. And first, to my immediate right, Dr. Philip Bialer, MD. He's a psychiatrist with expertise in the care and management of people with illnesses, including cancer and HIV/AIDS. One of Dr. Bialer's key colleagues is immediately to his right, and that's Allison Applebaum, PhD. Dr. Applebaum is a licensed clinical psychologist who specializes in helping patients with cancer and their caregivers. And finally, Dr. Andrew Epstein, MD. He's a board-certified medical oncologist and physician, caring primarily for patients with pancreas, biliary, esophagastric, and other gastrointestinal cancers. Communication in its own way is really every bit as complicated as other areas of cancer research and treatment. As we all know from personal experience, talking to our fellow humans can be tricky, fraught with pitfalls, misunderstandings, and missed opportunities. Memorial Sloan Kettering has special expertise in this area. It has the largest psychiatry department of any cancer center and is also a leader in training physicians and other staff in communicating effectively and compassionately with patients. But communication is much more than just how a physician interacts with a patient. It also encompasses interactions that physicians have with caregivers and family members. And an often overlooked but just as vital relationship is the communication between the patient and the caregiver and the rest of family and friends. All of these conversations, or lack thereof, can affect the levels of anxiety, stress, and depression in patients and caregivers. This can also have a significant impact on the quality of life and even eventually on family dynamics. We're going to begin with a brief excerpt that I want to read from a recent essay by a Sloan Kettering physician, Marty Hensley. It was recently published in the Journal of Clinical Oncology and addressed a question most oncologists have been asked at some point. How do you do what you do? People ask me this all the time. Trying to explain how oncologists willingly care for people who die is just too complicated. But sometimes a student or a fellow is candid and courageous enough to ask me, truly seeking an answer, how do you tell a patient that she is dying? So Dr. Epstein, my question is this. The ability for doctors to communicate in a positive way with cancer patients requires extraordinary empathy. A lot of people think that's an innate skill. You're either born with it or you're not. You're either an empathic person or you're not. Is that true, or is it a teachable skill?
I'd definitely be on the side of it being a teachable skill, and I agree that it's one of the most challenging questions that oncologists or any clinician caring for someone with a serious illness can be posed, and I commended Dr. Hensley for giving of herself to what is a large readership in our main oncology journal. It's really a challenging balance for all of us as clinicians to strike, and I think that empathy, or trying to put yourself in someone's shoes and inquire about their emotion is crucial to it. I think it's a teachable skill. Everyone here tries to do that, and I've learned it in different forms, whether it was learning from Dr. Bialer himself or other forums that exist on trying to teach communication. That empathy is a core part of it, and I think, as we'll touch on, a vastly underutilized skill that we as clinicians, especially doctors, need to be doing more.
Earlier, I alluded to the fact that caregivers, not the patient, are often overlooked by medical professionals when it comes to effective cancer communication. Do you believe that caregivers could be an important untapped resource in this dynamic? How so?
Caregivers are absolutely an untapped resource. They're often overlooked by medical professionals. Caregivers are on the front lines. They are intimately familiar with the day-to-day experience of cancer and its treatment, of the lived experience of side effects, and they're aware more so than any medical professional could be of the quality of life of patients. And as such, they really should be integrated into the medical encounter. Oftentimes in my clinic, caregivers will say to me that they felt invisible in the treatment room. And this is a reality that needs to be adjusted. Caregivers are a significant component of the healthcare system in the United States today, and as such should be looked upon by healthcare professionals as members of the treatment team, resources for data, and individuals who can help the physicians to make decisions that are really in line with the goals of both the patient and the family.
Sloan Kettering's communication training program, known as ComSkill, is designed to train fellows, residents, and other healthcare professionals how to communicate more effectively. How do these improved skills in this area translate into a benefit for the patient?
That's a good question. We're trying to evaluate that a little bit more, how improving communication skills for all of our fellows and residents and faculty, how that does benefit the patient. And we actually just finished a 5-year grant-funded program trying to evaluate that. We're still trying to put together all the data and see what the data shows. But some of our preliminary results show that patients, and the way we actually looked at this, we were video recording interactions in the clinic setting, doctors speaking with patients. And we had ways of coding to see which kinds of skills they were using, how compassionate, how empathic they were. And we asked for patients to comment on this interaction after they were done. And we would look at these recordings before and after the training that the doctors went through. So some of our preliminary results are showing that patients after the doctors went through the training, were more satisfied with their interaction. Many of their communication needs, unmet communication needs, were being met. They felt well, first of all, I'd say our doctors here, I think the doctors here are pretty special, and I think they started with a very high level of empathic skills. But there was some improvement, and patients were saying that they felt the doctors were listening to them more. They were responding to their emotional needs more, and but we're finding that the training is helping in terms of patients having a better understanding of what's going on with their diagnosis, having a better understanding of what's the treatment that's being offered, having a better understanding of their prognosis. We may not be able to teach someone to be a more feeling person. I mean, each doctor is an individual, and they come with their own set of interpersonal and individual ways they react emotionally. But we can teach people to communicate more empathically and to behave more empathically, and that's also what our program is demonstrating.
There seems to be some generational differences in terms of how much information, how it's conveyed, and so forth. My aunt died of breast cancer, probably never knowing that she had breast cancer. You know, this is from a Cuban sort of background, and you never use the C word, and they never wanted to tell her. How do you deal with that?
I smile because that's not an unusual situation that we face, especially in the hospital setting. And I smile because I would bet that your grandmother knew. I would bet that she did know to some degree something was wrong and that she did have cancer. And I point that out because I think that's why I think it's so important to, again, ask the patient what they want to know. And I think families sometimes can be very protective of each other. They're afraid they're going to upset the grandmother, or the grandmother's going to upset the family. But I think, at least in private, ask her what does she want to know about her illness. And she might say, I don't really want to know too much. I'm fine. Just let me be. And that's fine. I think we should respect her wishes. But if she wants the doctor to talk with her, I think that's an opportunity. Again, ask her what she wants to know, and an opportunity to talk with her openly and give her the chance to express her concerns, her worries, and so on. Learn who your individual patient is, what's important to them, what do they want to know, what do they want to discuss. It's very important.
But Dr. Applebaum, the caregiver and the family often interferes with that communication.
Interferes or perhaps augments
okay.
Challenges. It depends. We can look at this as patient-centered care or family-centered care, right? And that oftentimes it's not just about making sure that the needs of the patients are met, but because caregivers are so intimately involved in all of the decisions that are made and all of the steps that go on, that their wishes also need to be taken into consideration. And oftentimes what's manifesting in the treatment room, that's the culmination of many, many, many generations of tradition and generations of silence, for example, perhaps in different cultures. But certainly the family's desires need to be taken into account. So I wouldn't necessarily look at them as hindering. Perhaps they can even augment or facilitate the conversation.
Under good circumstances, but we're here to talk about the problems.
Sure.
And what they're going to do, because they will often want to be protective, not always in a, and that's not always productive, right?
Sure. And I think the best way to protect against that and to make these conversations as most productive as possible is for patients and families to have discussions long before they get into the room with their physicians about what their goals are for that medical encounter. Caregivers should ask permission to ask questions. Is it okay if I ask your doctor X, Y, and Z? Are you okay with that? Or what would you like me to not ask? That way, nobody's toes are stepped on and everyone's goals are really met.
Dr. Epstein, tell me about, the really important thing that is going to make all of this much easier is trust. How do you build or develop that trust, both with the patient and the family?
It's very important, and it's extremely challenging. And linking to what you both were saying, I tend to agree with you both. There are myriad situations that occur, and sometimes it will be interference, usually unintentional or well-intentioned, but producing interference, and often it's going to be something that augments, but always you have to try as the clinician to create trust such that you have teamwork rather than antagonism, which unfortunately occurs not infrequently. So I couldn't agree more with Dr. Applebaum that the caregivers are essential parts, because it's not that they're patients as well that you're caring for, but you are caring for another human being who is verifiably concerned about their loved one, and they're usually anxious and terrified and scared and going through a lot of emotions. And you have to use empathy not only with the patient, but with the family members also. So for instance, when I'm approached with the request to not tell the patients, if a family member approaches me or one of my colleagues, please don't tell my loved one they have cancer. It's a challenging situation, but it's an opportunity to turn potential interference or potential antagonism into teamwork and bonds and a journey that you can travel with the patient and family together. I say, what are your concerns about them knowing? And they might say something like, well, it will devastate them. Or if he knows, then he'll, quote, give up. Or in my culture, we X, Y, and Z. We defer to family members. And then I empathize with that, and I say, wow, it's clear that you really are concerned about them. Let's work on this together. Let's go into the room. And I am obligated to address, as Dr. Bialer said, what the patient, him or herself, want to know. But I promise you I will try to be sensitive, and hopefully you see that, and we can take it from there. And then in the room, I say, Mr. Smith, and I say this to everyone, when talking about health situations, some people want to know all information, some people want to know nothing, and some people want to know everything kind of in between, most details but not all details. What about you? And I think that trust can be built if the family member sees that you're trying, you're recognizing their concerns, to not, as we say, dump information on them, and at the same time to honor the patient's autonomy to, as Dr. Bialer said, have the information that they may or may not want to know.
Let me ask you about what I think a lot of people, in a sense, it's almost the elephant in the room, which is the question that everybody seems to want to ask the physician is prognostic information. How am I going to do? How much time do I have? That always seems to be one of the toughest questions to address. How do you deal with that?
If they really say they want as much information as possible, we can try to give that to them. In our program, we try to teach our doctors to give a range if patients want specific. Sometimes patients want specific numbers, or they want percentages. Sometimes they want to see diagrams. But we talk about talking to the patient about the most likely scenario, the best possible scenario, and the worst case scenario. We try to talk about a range, because we can't always be specific about the person in front of us, but we can give them a range to to consider for their specific disease?
There's so much information, treatments, appointments. There'll be multiple appointments to keep track of all kinds of things that are all going to be part of this. And is there a preparation coming to the appointments that's important, that in addition to, of course, as you mentioned, patient and the caregiver need to have their discussions beforehand, but what kind of preparation, what other preparation should be done?
I encourage all of the caregivers in my clinic to try to get a good night's sleep before important medical visits, and also to do something that will take their minds off of the current situation, just even for a few minutes, so that they can have a clearer mind beforehand. That really will help for more effective communication in the moment.
And Dr. Epstein, all of this gets all the more important and difficult as the treatment and disease becomes more complex, because then you really have so much more to deal with. Do you suggest sometimes to caregiver or patient certain things they might want to be, like write down your questions, make sure you come in with questions and you're preparing for your next appointment?
I think that's an easy and definitely important thing, writing down questions, especially, as you said, as things become more complicated. We find that patients and caregivers can get into a sort of flow, if you will. They'll become accustomed to everything from where they park and how they check in, to how long it takes for the doctor to see them and have their chemotherapy and so on and so forth. So they become really accustomed to things, in a lot of ways more comfortable, but as Dr. Gomez alluded to, things very often become extremely complicated as a disease gets worse and death approaches. And so that's where it's really important, not only for the patient and the family, but the clinical team, to be aware that things are getting complicated. And what we try to do when we teach communication is to do simple things, inquire about simple things that are really amazingly under-asked and underutilized, since we don't teach them in medical training, such as checking in about, a lot is going on right now. What are your concerns? What is important to you? And Atul Gawande said it really very well in his book, Being Mortal, that we've failed as a medical society, and particularly in the United States, to care more about simply living longer and how to address what's important to patients when they have serious illnesses. And he says it amazingly simply when he says the best way to do it is simply to ask them, what is important to you in the future? What are you hoping? What are your concerns? Questions like this are open-ended, and they're necessary.
This patient-caregiver communication, sometimes there's for lack of a better term, a conspiracy of silence between the two of them. Neither one wants to bring up something that might upset the other. Tell me about that.
This conspiracy of silence is something I see so often in my clinic, where caregivers will come in and say to me, I just don't want to tell him how I'm feeling. It's going to upset him. And most often, whatever the caregiver is feeling or whatever the caregiver is concerned about, those exact same thoughts are being had by his or her loved one. And what happens is, in effect, by not speaking and not asking questions and not sharing, gosh, what the doctor said to me is so overwhelming. I don't even know what to do with this information. That gives permission to the loved one to be silent. So when one person is silent, the other person is now given permission to be silent. And that creates a disconnect and distance between the two. So I do encourage my patients to think about the fact that likely there's nothing that they're thinking about that their loved one has not thought about at least once. And wouldn't it be great to connect and think together? And I say that these are opportunities that can bring family members closer together or push them apart. So it's really in allowing oneself to begin to speak openly with their loved ones about fears that can bring families together.
Well, tell me about that, because I think most people think of it as a difficult diagnosis, such as cancer, can only add stress to a relationship which inevitably is going to drive the relationship apart or drive a wedge in the relationship, sure. But not necessarily?
No, I tell caregivers in my clinic that cancer is the reason you're coming to me, but it's not necessarily the only thing we're going to talk about. And in effect, what oftentimes happens is that it's an opportunity for a couple, for example, a partner or spousal relationship, to test the strength of that relationship, to recognize how great they are at communicating, how courageous they are in tackling the big questions. Or it's an opportunity to recognize what areas can we work on as a couple or as a family. So really, it's an opportunity for growth.
Obviously, as we said, having a second set of ears and eyes and brain at a given appointment is really important. Do you find very often, though, that patients will try to come in on their own, thinking that I can do this on my own, I'm a tough guy or a tough woman?
That happens, and we hear patients commonly say they don't want to be a burden on others, and often, or more often, that happens at the end of life where patients are dying, and they express that one of their main concerns, usually when it's inquired about, is that they don't want to be a burden on their loved ones. And so more in the active phase of treatment where people are coming and going from clinic, it's less common, but I still see it manifesting. I'll say, oh, Mr. Smith, you're here by yourself today. Are you come on your own? And they'll say, well, I had my sister wait in the waiting room, or my cousin's kind of out with the car right now. I don't want to scare her, or I don't want to get her involved. And that's also a manifestation of not wanting to be a burden on others. And sometimes it's that'll fly, and sometimes I'll say, I hear where you're coming from, and I'm glad you feel that you're coping well on your own, and I think you are. At the time when we get a scan, I always think that it's a good idea for someone else to be there, and I tell them that, particularly around scans where there's a lot of information that we're going to be communicating, and those second set of ears are usually much more helpful than hurtful to that second set of ears.
What about the end-of-life discussions? How does that come up, and at what point does that come up?
Well, in terms of working with families, I encourage them to engage in these conversations early on. So as soon as there's some indication that it's possible that there may be no cure, and that hope for cure is no longer there, though there may be some hope for quality of life, that engaging those conversations early is critical. There's so many decisions that need to be made early on that it's best to engage in conversations about those as early as possible. It takes a while to adjust to a diagnosis of cancer, and when one has been going through many, many treatments, and eventually when treatments stop working, it takes some time to adjust to that reality as well. And so those conversations oftentimes need to happen again and again and again. Everyone up here, we've talked about having a lot of communication. It doesn't just mean one conversation about one topic, but actually repeating that conversation at various points during the cancer journey.
I know plenty of people who are even relatively rational people who become very superstitious at this point, that if we have an end-of-life discussion, it's going to become a self-fulfilling discussion and prophecy.
And that's what we call magical thinking. The idea that if we are to talk about the possibility of end of life, that end of life would come sooner. And the reality is that there's absolutely no connection between that. In fact, the more and more we can bring that elephant into the room, the better capable a family will be of handling that outcome, should that outcome come to pass.
Let's talk a little bit more about caregiver and something that I think was a term, I don't know if you coined it, but I heard it from you, compassion fatigue, that there's only so much in that well.
The well is usually very deep, but the well does often need to be replenished. Being a caregiver is a full-time job. It's an extraordinarily difficult one. It's also an opportunity for extraordinary meaning-making, and for a caregiver to find a great sense of purpose in his or herself. And so while there can be, we talk about burden, and burden can be physical burden, exhaustion, their own medical problems, psychological burden, anxiety and depression, existential burden. Why is this happening? What did we do as a family? Is there a God? All the questions that come up for all of us in hard situations. But it's important to recognize the signs and symptoms of burden, because if a caregiver if that bucket is at empty, that caregiver cannot perform his or her role, and is going to be less effective at communication both outside and inside the treatment room. And that's why, was one of the reasons why I started the program that I did, to help provide a space for caregivers to replenish that bucket, to learn skills to be resilient, to recognize that it's okay to not always be able to feel like they can support their loved ones. It's okay to feel angry. It's okay to feel guilty. It's okay to feel lots of very negative emotions about lots of many different things. It's all normal. One of the reasons why we've set up in this institution a caregiver-to-caregiver mentoring program is for caregivers to have peers who've been through similar circumstances and who can appreciate the unique experience they're having, and also helping caregivers to recognize that it might also be okay to tell their loved one, you know what, this is hard. I need a little break tonight.
Let's talk about how you help physicians become these better communicators. You're dealing with that, Dr. Bialer, with ComSkill.
Right.
All of us as human beings, I think, have defense mechanisms. Nobody likes to deliver bad news. Is part of this getting them to overcome these natural defense mechanisms? I think some of those defense mechanisms may turn you into what appears to be a less empathic person, no? You put up that wall because I got to deliver this bad news and then I'm out of here.
Right. So we do try to teach ways of doing that. Again, focusing on some issues such as empathy and how to give this information in a caring, again, patient-centered way. So I can tell you a little bit about how we do our training. Again, Dr. Epstein's been involved with this when he was a fellow, but also as a facilitator now. So we do our training with all the fellows and residents here in the institution, about 90 fellows and residents per year, and also faculty. And so we'll give a brief introductory lecture, but then we break off into role plays. We have actors trained as patients. We have scenarios written for their particular discipline. And we have the physician role play with the actor. And we give feedback on what they're doing, and we give them a chance to try again. And we give them an opportunity to try to learn new ways of communicating and doing this and breaking down some of the defenses.
I hope we've given you some food for thought. Thank you for watching and thank you for being here this evening. Have a great night.